My name is Jim Bodle. I have a PhD in experimental psychology with a focus on human development. I've been a professor at Mount St. Joseph for 23 years now, primarily teaching courses in human development and experimental psychology, but I also teach the course in history of psychology.
What's your stance on reinstating mental health hospitals? I guess we'll start with that.
Sure. I think that when deinstitutionalization happened, that there were other resources that were supposed to be put into place to help protect people from harm and to try to build a network of care, and that was really never done. And so we're in a position now where people who are mentally ill are much more vulnerable to homelessness. They're much more vulnerable to disease. They're much more vulnerable to be taken advantage of. And so I think that we're in a position where, just on those regards, we would be better off if we had institutions that could care for people. Plus, it's extremely challenging for people who are, say, wanting to go into drug rehab or other significant programs where it's a longer care. You can't really do it as outpatient as well as effectively as you could if you were in an institution. And so I definitely think that there's a gap. There's a significant need for mental hospitals. The few institutions that we have that provide mental care are overwhelmed. It's very difficult to get in, and there are so few that you can be in a region where there's really no facility available, within a reasonable distance. The history of mental health care in institutions is kind of a storied one. People really didn't systematically treat mental illness until really the 1800s, and it happened through a number of different means. Before that, people would be institutionalized either if they, as a result of a mental illness, committed some kind of crime, and then they would be in prison, or because of their mental illness they were in debt because they weren't capable of holding a job, and then also they would be in prison, debtor's prison. The 1800s really saw a rise in desire to treat mental illness in institutions for a number of different reasons. Some institutions were started by religious-based organizations, and those were often in a context of spiritual care. There were a number of different mental health movements in the early and middle 1800s that had a wide variety of ideas of why mental illness happened. Some of these were largely like rural based facilities where they thought that you could treat mental illness by getting people out of the city and into the open air. There were a number of institutions that were based on the idea that diet and exercise were probably an underlying cause of mental illness. And so you have places like the Kellogg Institute in Battle Creek, Michigan, where they believed that a vegetarian diet would treat mental illness. And so it's the reason that the Kellogg cereals exist, is that, Dr. Kellogg had this idea that, if we just give people a lot of dietary fiber and let them go out in the wilderness and run around and do exercise, that'll treat mental illness. So really the early treatment of mental illness in institutions in part was out of a desire to pull people out of society, because they thought that societal stress was a problem. That grew, unfortunately, often by the early 1900s, that grew more into a desire to institutionalize people, just to pull them out of the population where they were causing people discomfort or potentially causing harm, although that's really very rare. There was a big reform movement in the early 1900s called the mental hygiene movement. And one of the big advocates of the mental hygiene movement was a man named Clifford Beers, who himself had been very briefly, he was institutionalized longer than he should have been. He had a very brief psychotic break and tried to commit suicide by jumping out of their brownstone from an upper floor. He tried to impale himself on the wrought iron fence below, and he missed. His family was very concerned and had him institutionalized. He very quickly recovered, but remained in a couple of different mental institutions for a period of time. So even though clearly he had recovered, the treatment was not sensitive enough. They weren't monitoring his progress enough. And so he was institutionalized for a few years. And that was much longer than he needed to be. Probably needed to be institutionalized for a couple of months. And so Clifford Beers, once he was released, began advocating for reform in mental health treatment, and it grew into this thing called the mental hygiene movement, which eventually became the National Institutes for Mental Health. So its legacy is actually still in existence today. There was another attempt at reform that happened then in the 1960s, 50s and 60s, that came in part out of a study that was published called How to Be Sane in Insane Places. And the researchers had graduate students, of course, all research is done by graduate students. They had graduate students go into mental hospitals and claim that they were hearing voices that were saying empty, hollow, and thud. And that gave them a diagnosis of schizophrenia, undifferentiated schizophrenia. And they found that then, that once institutionalized, it was very difficult to get out. That again, the way that the systems were in place, any normal behavior that they would engage in sometimes was seen as a sign of their illness. So, as graduate students collecting data, they were taking notes, and the people who were charting them would chart, oh, and there's this compulsive note-taking behavior that they're engaging in. So, as part of the attempt at reform, that study was often cited as one of the indicators that we probably needed to change the way that we were treating mental health patients. Now, again, that doesn't mean you don't always throw out the baby with the bathwater, though. You don't necessarily close the institutions just because there were practices in place that weren't always appropriate. But that was ultimately what happened. That, along with the introduction of some of the early psychoactive medications, led to a movement to deinstitutionalize people. And so a large number of state and regional mental hospitals were closed by the 70s and early 80s.
So the concept of moral care was developed in like the Florence Nightingale era.
Yeah, the mid to late 1800s.
Bringing that back today, do you see that as a viable option for treating mentally ill patients?
There definitely are places where part of the illness has to do with the systems that people are involved in, the places where they are. Certainly, addictions are often triggered, for example, by cues in the environment. You know, people, for example, use drugs or alcohol because of certain triggers that are in their environment, and so moving people from that environment to another environment could be useful. And definitely the idea of moral care lends itself to a more complete, a more holistic approach, that medication alone is not the best source, but that that mental illness and its treatment are a piece of a larger set of lifestyle issues. And so certainly I think there's a place for that. And in psychology, at least in clinical psychology, the medical psychosocial model that is in place is very much in line with Florence Nightingale's ideas, I think.
What are some of the narratives that you find in popular culture that are kind of hindering this progress towards better treatments for mentally ill people?
Yeah. We still haven't completely disconnected the idea that mental illness is somehow a personal failing. You know, one thing that I've campaigned for example, in church, you pray for a person's broken leg, you pray for a person's cancer. Nobody would ever think of, or few people would ever think of asking for a prayer for somebody's schizophrenia or bipolar disorder or chronic depression. And yet it's every bit as much an illness as a broken leg or cancer is. So I think that we have, in part a narrative that says that mental illness is somehow a personal failing, that, you know, if you just sucked it up, somehow you would be able to get over your anxiety or your depression or your mood disorders or your addiction. And it's not a personal failing. There's a medical component to most significant psychological disorders. And so just as you need to look at the whole treatment of cancer, you need to look at the whole treatment of mental illness. So I think that's an important narrative that gets in the way of treatment. I also think that if we're thinking about institutionalization, or if we're talking about mental hospitals, we still strongly have a narrative that says that mental hospitals were horrible places. And that's not universally true. What was true was that we societally did try at times to warehouse people who made us uncomfortable, you know. And so, like, the Kennedy family, for example, is you know, part of that narrative of how many people know about the Kennedy sister who was institutionalized because her illness was something that Joe Kennedy just didn't want to sort of have widely known. Now, that's one case, but that case gets brought up so many times that it becomes part of this narrative that says that associates mental hospitals with abuse, mental hospitals with stigma, and somehow you feel like you're being kinder to people if you don't think about creating mental hospitals. Well, that's not true, and often mental hospitals could be a very good way of beginning a very serious program of care for someone who has a significant emotional concern, or significant, so again, depression, bipolar disorder, or someone who is beginning treatment for schizophrenia, beginning treatment for an addiction. You know, often it needs to be a piece of a much larger piece of care, and you can't seriously start treatment for some chronic conditions without changing the environment for at least a period of time. But again, we have this narrative that says that mental hospitals were horrible. You know, people still watch One Flew Over the Cuckoo's Nest or other movies or plays that involve mental illness in hospitals. So I think those are two really important narratives, with this sense of personal failing and the sense of mental hospitals themselves as being bad places. You know, I think those are two critical narratives that we really need to overcome.
Would you say that that bringing back mental health hospitals should be part of a greater, more holistic transformation of how we think of mental health in our society?
I think so. I think that we need to see mental health as a larger part of health. And, you know, we're beginning, for example, to say that part of the treatment of some conditions is a look also at the person's exercise or diet patterns, but we're not nearly as forgiving and as holistically thinking when we think of mental illness. And so we need to begin to think of mental illness as, in part, a failure of coping, and which is also in part sort of larger look at lifestyle. And that necessarily could be a part of, you know, the value of a hospital, because you know, just as, say, a person who has a chronic condition that leads to, say, balance or falling issues, you may initially want to treat them by putting them in an institution that is safe, physically safe, and then gradually transition them back into their home once the home has been transformed to be physically safe for the person who now has a mobility issue. I think likewise, if you look at the ways in which our social environment contributes to issues around mental illness, a hospital and then a transition period or a transition unit could be a very valuable way of treating mental illness.
What are some things that people who are not necessarily doctors
Mm-hmm.
can do to assist in this process of transformation?
Well, definitely advocacy and voting. I think that, you know, raising awareness and certainly based on voting. If there are levies in your community that have to do with raising money for mental illness or treatment, do it. I think that there's little knowledge among sort of common people among the general population about how difficult it is for mental health practitioners to get in with a number of healthcare insurance systems. And so there are often far more people in a community who are trained and licensed and capable of providing care than the insurance companies will certify. And so advocacy, in whatever way we can advocate for our insurance companies to open themselves up for more health providers, that's definitely an advocacy piece too, but also not contributing to the narratives about mental health issues as a personal failing, not othering people with mental illness. That's a really significant problem that I hear among people, that somehow we see people with mental illness as a whole different class of people. And the fact is that any one of us is one check mark away in the DSM from having a mental illness. I like to point out in Intro to Psychology, the difference between depression and feeling a little sad is 2 weeks. You're a little sad and you happen to miss school one day because you can't quite get out of bed. It happens off and on a few times. You don't have depression. It happens chronically for 2 weeks. Now you have depression, according to the DSM. So the difference is often just 1 or 2 check marks away. And I think it's the American Psychiatric Association, in their last version of the DSM, was really advocating for that awareness, in that they started to use this idea of continuum or the idea of spectrum more often. So like autism spectrum disorder, depressive disorder, schizophrenia, schizophrenic spectrum disorder, all of those cases are places where they're trying to say, look, there's a whole continuum, and many of us have qualities that are like a disorder but don't officially count as a disorder because we haven't quite reached those critical check marks in the box. But again, I think that not othering of people and owning the fact that many of us have qualities that are like depression or that are like bipolar, but we don't officially have the disorder because we don't quite have every check mark crossed in the diagnosis. I think that can go a long way toward helping raise awareness for mental illness, but also in the treatment, in that whenever we treat people as an us and a them, an other, it really dehumanizes and therefore takes away from our possibility of care.